Hello everyone, I am Dr. Deidre O'Donnell. I'm a Paediatric emergency medicine consultant and dermatology associate, and you're all very welcome to my talk on emergency and urgent paediatric dermatology problems that we all see on a regular basis. Hopefully I'll be able to give you some tips on how to approach things even when we're not really sure what's going on. So why should we care about this at all? Well, skin matters. So skin problems matter. Skin's the biggest organ in your body. It's a key part of your immune system and protection against the outside world. It regulates your temperature and your fluid use. It's jam-packed with pain and pressure receptors. And it's public, obviously. If you were a kid, would you play with a kid with skin like this? Would you shake hands with this person? How about if it was your doctor or nurse? Would you be worried about catching something or being contaminated? People make judgments and can treat you differently depending on your skin, especially children. Chronic skin conditions are a massive source of stress to both the person and the whole family. The reason I first got interested in this was a paper in 2006, which was a comparative study of impairment of quality of life in children with skin disease and children with other chronic childhood diseases. And the paper demonstrated that family stress and disruption was higher for severe eczema, higher than asthma, higher than epilepsy, even than for cystic fibrosis. Dermatology treatment is often unpleasant, messy, labour-intensive and long-term. Kids are very self-conscious. Their skin keeps them awake at night. It might smell funny. The treatment might smell funny too, or be sticky, or make them look pale or dusty. It disrupts school, play, eating and sleeping. Access to expert dermatology opinion is difficult, and they also don't get involved with acute minor rashes. Those rashes are usually gone by the time a clinic appointment for dermatology comes around. So it's incredibly useful for primary care, pre-hospital and emergency healthcare staff to develop some basic skills in derm. I think it's easy to get from useless to useful with a few bits of information. Well, of course, becoming an expert takes a whole lifetime. But let's have a look. So you can learn a list of rashes and their names, their causes, common and not so common skin problems. The diagnosis is generally the description, but in Latin, like erythroderma means red skin. Acrodermatitis, inflammation, itis of the skin, derm on the hands and feet, acral, very cunning. Or better still, if you learn a system or mind map on how to approach skin problems to lead you in a sensible direction. So let me show you what I do. So this is one totally unvalidated way of thinking about a rash, and it's what I use in my head in the ED. And these are pretty much all the rashes that I know about or generally care about. So you start off, is this a normal child with a normal rash? That takes quite a lot of experience. There are lots of neonatal rashes that are absolutely routine, and the child is well. That's what's quite important. So we will have in our armoury or in our encyclopedia a handful of normal rashes like milia, erythema neonatorum, dribble rash, seborrheic dermatitis, mild stuff. But then we're looking at the child who isn't quite normal, or it's an unusual rash, or often at a different stage of life. So then we have to work out, is this child well or unwell? Obviously, if they're unwell, the resuscitation takes priority over everything else, A, B, C, D. Doesn't matter what rash you've got. But then between the unwell and the well, if we go down the well panel, they look pretty good. It can be infection, immune, or trauma in general. Then within infection, it can be viral or bacterial. Infestation is probably what you would call a subgroup of infection, and that would be something like scabies, head lice, things that when you've seen a few of them, they're usually fairly obvious. And often the difference between the left-hand column and the right-hand column here is just how unwell they are. It can be the exact same infection, but just much more severe. So if you have a relatively well-looking child and you suspect that it's infection, maybe they have some upper respiratory tract symptoms as well, then you'll go down the pathway of a well child with infection. Could be viral. Is it molluscum, which are little pearl-coloured lumps with very key and umbilication, like a little dent in the middle of them? parvovirus, Coxsackie virus, roseola, they have particular patterns, which I'm not going to go into in great detail here. They're easy to Google. If you're looking at hand, foot and mouth, the clue is they're on the hands, feet and mouth. If it's roseola, the key for roseola is they've had upper respiratory symptoms with a high temperature, and the day the temperature stops, then this florid rash comes out. So the key is the timing of when that rash was, rather than the picture of the rash itself. Mild bacterial infections, you will know things like impetigo, which tends to have a yellow crust, tends to be on the face, tends to run in the family. Paronychia is obviously infection of the nail beds and the nail edges, but if you don't look, you're not going to see it, and one of those can spread to the other. Then you go on to your essentially immune disorders like eczema, psoriasis, and erythema multiforme. But again, I wouldn't expect pre-hospitally somebody to diagnose erythema multiforme, but you can have it in your mind in this process. And obviously trauma causes scratches, bruises, erythema. Then we look at unwell children. Again, they can be infection, immunity, and trauma. There aren't too many infestations that are very severe, though Norwegian scabies is probably an exception. I've never seen it. Infection-wise, the big one is invasive bacterial infection. So meningococcal or group A strep, both of them can cause purpura. And purpura is non-blanching and it's big, as in bigger than a millimetre, bigger than tiny dots. Infections that can be quite severe and make a child very unwell include chickenpox and measles. And the nature of those is quite specific. So chickenpox will come up as a little bump, then it will turn into a clear fluid-filled vesicle, then it will crust, and then it also might become pus-filled because they get secondary bacterial infection very easily. Measles, on the other hand, is not a raised rash. It's flat. It's sometimes a little bit rough, but it starts on the face and spreads down, and the child is generally fairly unwell with it. Obviously, it's on the increase in this country, and you really need to get a sense of the appearance of it. Check the books, check the encyclopedias. Do not check Google, because when you Google measles, you might end up with a chickenpox rash in the photograph and not know it. Then you have the serious immune rashes, like severe eczema, which can have eczema plus bacterial infection plus cellulitis plus viral superinfection all in the same place. Staphylococcal scalded skin and toxic shock are very severe. Stephen Johnson is very severe, and they're toxin mediated. The other thing to consider from an immune point of view is epidermolysis bullosa. That is usually in neonates and involves peeling skin and skin coming apart at different levels. The other thing we have to consider with multiple marks on the skin is also trauma. Again, bruises and purpura can present that way. So there are small clues that help. Not strictly, but useful rule of thumb that I use all the time in the emergency department. So vesicles, which are little fluid-filled blisters or bumps, tends to be the herpes virus family. So shingles, chickenpox, herpes simplex. If something is itchy, it tends to be viral or fungal or eczema, or all three. A yellow sheen or a golden sheen suggests Staph aureus, because aureus means golden. A lot of lesions on the scalp are fungal. They're tinea. They may have associated lymphadenopathy and weeping and secondary bacterial infection, but almost everything I've seen on the scalp in an emergency department is a fungal infection, which often needs more than topical treatment. So you do need to get them seen either by the GP or an available doctor. Something that smells bad is usually bacterial or fungal. Painful skin, which is quite unusual actually in children, is generally bacterial. If it's normal looking skin but it's tender, be very anxious about bacterial infection. If other family members are affected, I tend to think scabies, tinea or ringworm, bedbugs or impetigo. If there's a very regular or unusual outline, you must consider trauma or NAI. Marks of a hot branding implement, for example, pressure that can include coining or cupping marks, We had a run one summer of 6 to 9 year olds with linea purpura on their legs in the department. Turns out they'd all been to Laser Quest the same day, and the harness caused regular purpura on the thighs. Very simple explanation, but it took us a while to work out what was going on. There's also a pretty rare condition called dermatitis artefacta, where the patient has self-inflicted skin lesions. Sometimes purpura from aerosol burns or pen lids or chemical application. They're often more florid on the non-dominant side. So if you're right-handed, you'll create lesions on your left, and it will only occur where the patient can reach. It's a type of self-harm and tends to take a long time to diagnose, really, and to get the patient and the family on board that this is not some incredibly unusual coagulopathy or, infection. So you can learn a system, or you can learn a list of rashes, or you can learn a system and a mind map on how to approach skin problems. So my second piece of advice is be afraid of purpura, but not too afraid. Thankfully, meningococcal sepsis has been reducing in the UK over the last 20 years. Steady reduction, which had a massive drop during the pandemic due to lockdowns, and has increased a bit year on year since, but it's still the thing we all worry about with sick kids. So this sort of rash is the one that we're all panicking about or very worried about. Totally legitimate. But in a way, they're quite straightforward. They'll be pretty sick, even though they might be quite alert. Fire the antibiotics into them as fast as you can, as with JR Calc 2022. Resuscitate them with fluids, keep them warm, and get them to the most senior person in tertiary care as fast as you can. The factors which influence survival in these kids is early inotropes, aggressive resuscitation, tertiary care, and senior review. It's thankfully reducing due to our good old friend vaccination, but it's still a nightmare for parents and healthcare workers. But remember, only about a third of meningococcal sepsis will have this rash, and a decent proportion will have a blanching, what they call evanescent, which means fading rash, fairly early on in the illness too. Plus, for another big worry, is that this can occur in any septic child regardless of cause. I've seen this purpura particularly aggressive in a child with chickenpox and invasive group A strep, and unfortunately they did not survive. But when you see a rash like this, there's no doubt about what you need to do. But you'll also be called to kids like this who don't look sick at all. This kid on the left is upright, unsupported. They might have ITP or HSP, idiopathic thrombocytopenic purpura or Henoch-Schönlein purpura. These are non-blanching rashes, or largely non-blanching. But I think it would be foolish to sit on this at home, or advise the parents to sit on this at home. In ED, at least we have the luxury of time. We can assess how it has changed since it was first noticed, how the child's situation changes. Is it moving fast? Is it moving slow? Is it fading? From a pre-hospital point of view, it's useful to draw around a lesion if you can, just with a normal pen, and then we can track it over time very easily. Photos are brilliant. On the parent's smartphone is the easiest place to get those. We no longer investigate all of these children in my department, but we do take a fair amount of time to decide to do that. If they are perfectly well, all vitals normal, no fever, no nothing, you can justify pre-hospital not giving them IM Ben pen, but I would still get them to an ED pretty sharpish. They'll be up triaged at Peds ED because even we're a bit nervy about non-blanching rashes. The other thing just to tell you about these, if this child is fine and dancing around, don't be afraid to wipe this rash with an alcohol wipe. As all of my colleagues in Peds ED, myself included, have seen a magic marker pathology at some point, and it saves everybody a lot of time and worry if you double check that it really is purpura and really is a rash. So top tip number 4 is temperature after day 3 of the rash in chickenpox is not due to the chickenpox itself. So chickenpox, as you know, is a super common, super contagious childhood disease, about 3 per 1,000 population incidence. The incubation is 10 to 21 days. So up to 3 weeks after you've had contact with someone you may or may not realise has chickenpox. It mainly affects under 10s. It starts with a mild head cold, runny nose, sore throat, cough, which we call a urty or viral prodrome. And then the spots appear a day or two later, not a week later. And they will start off being a small bump, a small solid bump. Then they will turn liquid filled into a vesicle, and then they will crust. Once they're all crusted, the child's not contagious anymore and everything will resolve, but can take weeks for the spots to resolve. You can see here a really classic finding in the middle of this child's back. It's called a dewdrop on a rose petal. So you have this reddish pink blush base and then a little clear bubble over the top of it. Absolutely classic for chickenpox. Some people have a few, some people have loads. And it is usually intensely itchy. If it's not itchy and doesn't have this appearance, I would be suspicious that it might be another herpes virus rather than chickenpox itself. Anyway, it's usually mild or self-limiting, but can have bacterial superinfection. Mainly folliculitis or impetigo infection of the spots themselves, but it can also be invasive with things like pneumonia, empyema, meningoencephalitis, basically anywhere. And this is due to the immunosuppressive effect of the chickenpox allowing secondary bacteria to invade. So if the fever is persisting after day 3 in chickenpox, go looking for the infection or refer and send them in so somebody can look very, very hard for other sources of bacterial infection on top of this normal childhood viral infection. Top tip number 5 is be smart with steroids. Everybody's worried about putting steroids on children's skin. Parents are steroid phobic, GPs are steroid phobic, emergency doctors are also steroid phobic. But don't be, it can be life-changingly beneficial if used correctly. I mean, we all know that topical and oral steroids can have a broad range of side effects. The first thing we're taught in medical school is not to put steroids on infected skin, which is perfectly true, except in eczema. In infected eczema, you have infection plus inflammation. If you don't switch off the infection, you're never going to sort out the inflammation. If you don't switch off the inflammation, you're never going to be able to sort out the infection. These babies have often had multiple courses of antibiotics and changes of creams with very limited effect. They're usually very unhappy, as are their parents, having been up all night for weeks. These children must continue or even increase their steroids. Even parents who are worried about this will be very reluctant to put the right amount of the right strength on. They need clear guidance, lots of information, lots of reassurance and follow-up. The only exception to this is if you see or suspect herpes virus is involved. Then we would treat with antibiotics and antivirals until the vesicles dry up. Then we would get back to the steroid treatment. I think this might be my favourite top tip, is that tiny babies are a nightmare. I'm not messing. The neonates and babies have loads of skin conditions that are totally normal and benign, but they also have loads that are horrible or life-threatening. From a pre-hospital point of view, I would say don't take any chances. Get someone to see them. If the baby's super well, GP review within 24 hours is reasonable. Get the parents to take photos. Sometimes it's not even the rash itself that's of concern, it's the distribution of it. For example, something that looks like erythema neonatorum, light pink red bumps, which is a completely benign condition and really common. If that's only in the axilla and the groins and the neck folds, then it's more likely to be bacterial or candida, but it mightn't look impressive at all. Then simple stuff like milia, Epstein's pearls, even baby acne are all harmless, but they stress parents out massively. And it takes a while for paediatricians and GPs to become comfortable with this particular gang of rascally patients and their types of rashes. So my bottom line from a pre-hospital point of view is don't take any chances. If the baby's well, get them to see ideally their GP rather than somebody random in a walk-in centre, or PDD. I am happy to see these kids. Probably not true for most of my colleagues, But if you're worried about a baby, then you actually do need somebody to give you a definitive answer just to get reassurance. Like, this is an example of how difficult it is to be sure about anything. So what do you think of any of these spots? Yeah, the top row, you got a little white spot on the roof of the mouth, little white spots, sometimes fluid filled, sometimes dry on different parts of the skin. Then you've got red blotches on the back, a florid red spot on the forehead, little white spots on the nose. I can tell you now, these are normal, 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 and normal. But it is quite difficult to spot the difference. For example, look at this slide. You've got red fluid-filled vesicles. You have pustules with surrounding erythema. You've got lumps that are hard and nodular. Everything on this slide is staphylococcal skin infection, and very serious, especially in a neonate. So this is why they are so difficult, and I just wouldn't take any chances with a neonate. So top tip number 7 is that rashes that affect the mucous membranes, so the inside of the mouth, the eyelids, the vulva, should be taken deadly seriously. They could be something simple, but it could be something awful. They range from simple self-limiting viral infections like hand, foot and mouth. Not the same as cow, foot and mouth, but they're small, pink, slightly raised, solid lesions with a red ring around the edge. They're on the hands, foot and mouth. They're not painful, they're not itchy. The child is generally well, but possibly with a mild upper respiratory tract infection. It can sometimes spread to other body parts, but that's uncommon. Herpes simplex, for little kids, their first cold sore infection is often inside the mouth and the throat rather than along the lips and nostrils as it is in adults and older kids. Ask the family about other people getting cold sores. It's very painful having herpes stomatitis, so cold sore virus inside the mouth and throat, but it's not dangerous. Our priority is hydration and making sure the child drinks enough. It lasts about 10 days. Acyclovir is no use unless it's given within the first 3 days of the rash, and even then it is virustatic rather than virucidal, so it doesn't get rid of lesions that already exist. It just tries to reduce the number that are going to be produced. In my experience, once you think the child's at their worst, they seem to turn a corner just before you admit them for IV fluids. So simple but regular pain relief, Diflam, the local anaesthetic spray, and cold fluid or ice pops is what I usually give. Chickenpox can also have intraoral lesions, again very uncomfortable and likely to reduce a child's oral intake. The baddies when it comes to mucous membrane rashes include severe erythema multiforme leading to Stevens-Johnson syndrome or toxic epidermal necrolysis. Staph scalded skin syndrome usually spares the mucous membranes, but the lips can be very red and cracked. All of those children will be unwell, whether the trigger is medication or infection. So you would need to bring all of those into the ED for review. Top tip number 8 is to remember that rashes look different in different skin colours. Dermnet NZ has revamped its atlas to include more variety in skin types in the last few years. It's a really good resource, very visual, loads of photographs. Mind the Gap is a creation of a British medical student who noticed the lack of racial diversity in skin teaching, and it aims to close this knowledge gap. It's a small free to download book, and you're also invited to contribute via the blackandbrownskin.co.uk website. Particularly things like purpura and petechia and bruises are sometimes misinterpreted in darker skin. Scarring from eczema, the distribution of rashes, the absorbance of the skin for emollients can change depending on the racial or ethnic origin of the patient. So it's useful to expand your vocabulary and your memory bank for what things might look like in different skin colours. So number 9 top tip, you're nearly there, is try not to label a child allergic, particularly pre-hospital. Antibiotic and food allergies certainly exist, of course they do, but they're widely overdiagnosed. And I wouldn't expect someone pre-hospital to make a definitive inclusion or exclusion diagnosis on this, but you can avoid planting seeds in the parent's head. Many simple childhood viral infections have a non-specific rash associated with them. It can appear at any point in the illness. Similarly, viral-induced urticaria is fairly common. So suggesting that it was a medication, Calpol, a sandwich, Nurofen, whatever, isn't particularly helpful. Imagine the scene of a scenario of a child with a fever, cough, runny nose for a few days. Nursery won't have her. Parents need to take days off work. They go to a GP who might give some amoxicillin just in case. And a day or two later, the child comes out with a patchy rash on the skin. Obvious allergy? No. On further history taking, you find that the child has had some hives in small crops on and off since they first became unwell. Not a penicillin allergy. This is viral-induced urticaria. Misdiagnosed antibiotic allergies represent a risk to the patient in terms of receiving the correct drugs when they need them. A large financial burden to the NHS in terms of using alternatives, and also increased risk of development of C. diff and MRSA, ESBL issues due to incorrect antibiotic choices. Confirming drug allergies is a slow, expensive, multi-level test, so it's not done unless the history gives a reasonable suspicion. And in the ED, we can check mast cell tryptase to further confirm suspicions if needed. But planting the idea of allergy in the parent's head is very powerful, and they will often label or mislabel their child for that in the long term, which nobody will ever revisit formally. But if we take a really good history and are able to reassure them at the start, you can avoid that whole complications. So here we are at number 10. And again, this is a personal practice issue for me. So it's always to check or ask about the other members of the family. Does anybody else have this rash? Now, this can be a bit delicate because there's still a lot of stigma attached to certain skin conditions, but sometimes you might actually spot a spot on the hands, face, or scalp of the parent or another family member with them. These point to issues like scabies, bed bugs, tinea. Yellow blisters or crusts or pustules point to impetigo, which is super contagious, so of course somebody else in the family might have it. Or a parent might have a cold sore, while the toddler has loads of lesions in their mouth and throat, which would point to herpes simplex or stomatitis. And of course, treating only one family member is completely pointless in this situation. Also, parents are usually forthcoming when they've heard from nursery or a birthday party or whatever when a child has gotten sick, but it's worth asking specifically just in case. And for the more chronic or complicated problems, a family history of psoriasis, a family history of eczema is quite important to ask for as well. So I hope this has given you some useful small tips on how to approach the spotty, rashy kids that you will see very often in your practice. Most of the time it's not something horrible, which is reassuring, but it causes massive distress to kids and their parents. This is a few of my favourite websites because I have a special interest in skin. DermNet NZ is particularly good. CKS is the clinical knowledge summary for NICE about chickenpox, and that also gives you some clues about how safe ibuprofen is or isn't in that situation. The British Association of Dermatologists has a really easily accessible website with lots of information for parents. And as I said, BSBAD is for special dermatology nerds like me. And the Black and Brown Skin is a small website, but is increasing and would really appreciate any of us putting in new data that we can have. I am more than happy to go into any skin conditions for training for any of you, so please stay in touch with KidConfident if there's a particular area that you want me to cover from the emergency point of view. Bye. Thanks.